In this lecture, we're going to look at disorders of the neuromuscular junction. So myasthenia gravis, we'll look at multiple sclerosis, ALS, amyotrophic lateral sclerosis, and Gynberry syndrome. So first is myasthenia gravis. This is an autoimmune disorder of the neuromuscular junction, so where the nerve connects with skeletal muscles. Remember that a neurotransmitter used in that synapse is acetylcholine, and it binds to a nicotinic receptor in the skeletal muscle. So what happens is the immune system actually binds to that nicotinic acetylcholine receptor and creates antibodies against it, and that basically blocks that receptor from being stimulated. This most often affects young females, and it can be associated with thyroid toxicosis Graves' disease, which is an autoimmune thyroid disease, thymoma, which is enlargement of the thymus gland, or any other autoimmune disease. Presentation is going to be typically fluctuating fatigue. When the patient gets tired, they actually get ptosis, eyelid drooping, and double vision. So that's usually the first thing. So myasthenia gravis typically affects the small muscles in the body first, and then it progresses outward to larger muscles. So the very first one could be just eyelid droop. So you notice your patient just develops a sudden eyelid droop. They're female, they might have another autoimmune disease, again, like Hashimoto's or Graves' disease. Then they're going to be at higher risk for myasthenia gravis. There can be bulbar symptoms. Remember, the bulb is the medulla. So dysarthria, dysphagia, this is affecting the cranial nerves that affect the jaw and swallowing. So inability to speak or swallow. And then proximal muscle weakness. So the more proximal muscles in the body, again, proximal is more towards the midline, distal is more outward. So those muscles will start to get weak first. And then the symptoms typically worsen as the day progresses, so worsens with fatigue. Patients going to have difficulty climbing stairs, rising from the chair, brushing their hair, swallowing. Now rarely, and this is a medical emergency, the effects are on the phrenic nerve and its innervation with the diaphragm, and that can result in respiratory failure. So basically the patient can't breathe, and so they need a ventilator, and I'll talk about the treatment here for that in just a moment. Okay, so myasthenia gravis, body creates autoantibodies against the nicotinic acetylcholine receptor at the skeletal muscle junctions, and it blocks the ability of the nerve to stimulate the skeletal muscle. There was an old test, we rarely use it today, called an anticholinesterase test, when you would administer an anticholinesterase orally. Remember, the cholinesterase is the enzyme that breaks down acetylcholine, so this keeps more acetylcholine around. If symptoms improved with that, then that was kind of thought that would confirm the diagnosis of myasthenia gravis. That's called the edrophonium tensilon test. That's rarely done anymore. Typically what we do now is measure actually the ACH receptor antibodies. So we can actually have assays for those antibodies, and they're going to be positive in 80% of cases. There's also something called anti-muscle specific kinase, anti-MuSK, and that's positive in about 5% of cases. So we have a panel of biomarkers now that are typically used for myasthenia gravis. There's a high incidence of thymoma, enlarged thymus gland, and that is diagnosed via chest CT. And then other tests would be pulmonary function test to see what the patient's respiratory function is, if it's affecting their respiratory muscle, their phrenic nerve, and their diaphragm. And then there is something called the ICE test. Place a pack of ice on one eye for 5 minutes, and that resolves the ptosis transiently, and that's because we think it helps to unblock those antibodies temporarily. And then abnormal single fiber EMG, nerve stimulation test, these would be additional tests used to diagnose myasthenia gravis. So the treatment is really going to be symptomatically to use anticholinesterases. So pyridostigmine, neostigmine are commonly used. Those are going to just stimulate acetylcholine throughout the body, so they're not very specific, not just at the neuromuscular junction. So we can have other adverse effects that pretty much increase parasympathetic effects, so that might trigger actually more diarrhea and that sort of thing. So there are adverse effects from those. The primary treatment, though, is immunosuppressive. So prednisone, immunosuppressants like azathioprine, cyclosporine, and so forth. These would all be medications that are used. And then in severe cases, patients can actually undergo what's called plasmapheresis, where their blood is removed from the body, it's put through a special filter, and all of the autoantibodies to the neuromuscular junction are removed from the blood. And that can provide temporary relief for weeks or months, and that can be if the person's in respiratory failure from myasthenia gravis, that might be an emergent treatment to use. And then resection of the thymus. So the thymus, remember, is where T cells mature, so it becomes enlarged because they're just churning out more T cells as part of this immune response. So removing the thymus is another kind of option there. And then typically there's certain medications that are avoided, like beta blockers and certain antibiotics called aminoglycosides. So that would be the kind of biomedical treatment for myasthenia gravis. Don't know of a lot of adjunctive care measures that have been used for myasthenia gravis. So that's one that needs a little bit more research to see if there are other herbal therapies, etc., that might be helpful here as well. So that's our first neuromuscular disorder, myasthenia gravis. Our next disorder here is multiple sclerosis, MS. This affects the nerves. It's a demyelinating disease in the CNS. And you get multiple zones of demyelination, plaques, scattered throughout the white matter in the CNS. Remember, the white matter is your myelinated nerve tracts, both in the brain and spinal cord. Interestingly, MS spares the peripheral nervous system, so all the peripheral nerves from the spinal cord to the muscle are unaffected. But in the central nervous system, it can affect motor tracts, it can also affect sensory tracts and the autonomic tracts. So motor, sensory, and autonomic changes are all characteristic of MS. More common in females than males, and that's typical for, we think, the underlying etiology is autoimmune. The immune system, we think, attacks the myelin, and that's what causes the demyelination. There's, of course, on top of that, a genetic susceptibility, and potentially environmental triggers. There's some viruses that are suspected, some herpes viruses, which actually might be triggers like Epstein-Barr, cytomegalovirus, etc. But for the most part, autoimmune diseases are more common in females than males, and that's why it's more common here. The onset is between 20 and 40 years of age, most typically. And interestingly, there's increased incidence the further north you grow up from the equator, the higher the incidence of MS. So we think there's a sunlight vitamin D connection there. So there's a very low incidence of MS for children born around the equator, but as we go progressively more north or south, further away from the equator towards the poles, the incidence of MS increases. Now, that's where you were born and grew up, so a lot of people, of course, travel back and forth and they live different places where they didn't grow up. But if you look at where people were born and spent most of their early life, the incidence of MS in those people is less if they grew up close to the equator versus the poles. And again, we think that might be vitamin D as one factor there. Pregnancy decreases MS symptoms, and that's typical of most autoimmune diseases. Pregnancy decreases autoimmunity, and we'll talk about that later. There's a variety of factors that go into that. And there's several subtypes of MS. So when you hear a patient has MS, it's important to know which subtype they have, because some are more sort of concerning. They degenerate faster than others. Again, the pathogenesis, we think it's autoimmune, although we're not fully clear on the mechanisms. We think it's a T cell autoimmunity causing the demyelination, so the CD8 cells actually attack the myelin, destroy them, coupled with a genetic environmental susceptibility. The attacks are unpredictable. The average occurs every 1.5 years and lasts for up to 2 months and then resolves. So this is not uncommon for MS, where a patient will start developing MS symptoms and then it all resolves. And you think, oh, it's cured. And then it comes back and then it resolves and comes back and resolves. And so that's the most common pattern of MS. In some cases, unfortunately, it can just, you start developing symptoms and it just continually progresses. And so again, that's going to be the different subtypes we'll talk about here in a moment. So the basic presentation is with sensory deficits and fatigue. So again, it affects the sensory system, and that's often the initial symptoms. So you get decreased sensations or paresthesias in the upper or lower limbs. Symptoms often worsen with hot showers. So again, autoimmunity, I think, is driven deeper with, or immune inflammation with heat, versus cold, like we saw in the ice pack test with myasthenia gravis. It actually helps. The Lhermitte sign, this is a vibratory electrical sensation traveling up and down the neck and back with flexion. That's suggestive of MS. Now, I've seen a lot of patients postmenopausally that also develop this kind of electrical vibratory sensation, and that's more hormonal. But this is something, if they're having any of the other signs and symptoms here, to consider MS. So that's the first thing, is the sensory deficits. Then there are motor deficits, and that would be acute or gradual weakness and spasticity. And that can lead to weakness with paresthesias, hemiparesis, quadriparesis. So hemiparesis is weakness on one side of the body, quadriparesis is on both. And then over time, loss of bladder control. And then the visual disturbances. And in fact, in up to 20% of patients, one of the first symptoms is optic neuritis. So basically you get eye pain with vision loss. The patient says, my eyes hurt and my vision is not focused. So that's sometimes the first symptom in up to 20% of patients. Internuclear ophthalmoplegia, and that's going to be in the brainstem, and that's going to affect your cranial nerves, affecting the eye movements. So we start to see lateral gaze deficits, diplopia, double vision. And then Charcot's triad is scanning speech, the ophthalmoplegia symptoms, and then nystagmus, the beating of the eye back and forth. So all of those would be potential visual disturbances with MS. When the cerebellum is involved, we get ataxia, intentional tremor, and dysarthria. And then autonomic involvement, impotence, and constipation are common manifestations. We already mentioned the loss of bladder control as well. And then when the cerebrum is involved, and that's usually an advanced illness, there could be memory loss, personality changes, emotional lability, anxiety, depression. So think with MS, first thing usually is sensory deficits, paresthesias, maybe the optic symptoms, and then motor symptoms may develop at the same time or a little bit later with weakness and spasticity. And then again, depending if it affects the cerebellum or the cerebrum, different symptoms with that. So that's a typical kind of presentation of MS. Now I mentioned there are several different types. So the relapsing remitting is the most common type. So there are episodes of symptoms, they relapse, they go into, they have no symptoms. And the good thing about the classic relapsing remitting is that you get these white matter lesions. So when they're worked up with MRI, and usually contrast is used, you'll see in the brain and spinal cord these characteristic lesions, and that's due to the demyelination in those white matter tracts. In the relapsing remitting cases, during an actual active episode, there'll be demyelination, and then it relapses and the demyelination actually heals. And if you go back and do imaging, those lesions are gone. And the good thing about the relapsing remitting is that they have the best prognosis. We think there's no progression towards deeper sort of degeneration of the central nervous system. And there's usually full recovery after each episode of the deficits. Usually this is about 66% of all cases of MS. So they have the best prognosis. Going down the road, the prognosis worsens with primary progressing, secondary progressing, and rapidly the progressive relapsing. So with the primary progressing, you get the symptoms with no relapses. Progression really just starts from the onset. You get minor remissions with kind of plateaus that take place during the progression. This is about 19% of cases and not a good prognosis. Secondary progressing, there are some relapses. You have progression not at the onset, but later it progresses. So the difference with secondary and primary is from primary, you get progressing into worse disease from the very beginning. So no relapses, just progression. Secondary, it kind of starts off like relapsing remitting, and then it goes into progressive. This also has a bad prognosis. And the worst prognosis is probably the progressive relapsing. Really from the onset, you get a progression. You can have full recovery here, but eventually over time you lose central nervous function. So these demyelinated lesions are found all throughout the CNS. So relapsing remitting up to 66, about 2/3 of patients with MS have the best outcomes. They have episodes which then fully heal between each episode, and the others have worse prognoses. So the diagnosis is using what's called the McDonald criteria. You can look that up. There's no single confirmatory test, but it involves a lot of these signs and symptoms we've discussed, doing classic history and physical exam, and then MRI with contrast is going to show these multiple asymmetric, often periventricular, outside the ventricles, white matter lesions, and especially in the corpus callosum. And then the lesions are going to actually enhance with gadolinium, which is why we use the contrast there. And then lumbar puncture, the CSF will actually show mononuclear phagous pleocytosis with increased IgG antibodies. And there are what are called oligoclonal bands that are found. So you can do electrophoresis on that and see these specific bands in the CSF. So that's another diagnostic test, is a lumbar puncture. And then abnormal somatosensory and visual, what are called evoked potentials. So you give a stimulus and then see how that nerve fires from that stimulus might also be present. So that's all part of the workup of MS. So the treatment's going to be during the acute exacerbations or acute episodes. We're going to do typically biomedically corticosteroids are given. And for the optic neuritis, IV corticosteroids might be needed. And that just shuts down the immune system. After the relapse and the relapsing remitting, typically immunomodulators are given. So interferon, beta 1A or 1B, or copolymer 1. These are all immunomodulators. We now have what are called biologics. So biologics, we'll have to talk about these. When we talk about immunosuppressive drugs, they fall into two basic classes. There are the kind of chemical things the drugs that we take. So methotrexate's a good example. Cyclosporine, these kinds of things. We kind of talked about those already with the Myasthenia Gravis. So those are drug therapies. The newest line of immunosuppressants are antibodies. They're monoclonal antibodies that are injected, and they target usually one specific cytokine involved in autoimmunity, like TNF-alpha or IL-1 or IL-6, and they shut down that cytokine. So that's kind of the newest, latest, sort of greatest invention in the biomedical world is the biologics. As you can imagine, with shutting down TNF-alpha is tumor necrosis factor. This is used by the immune system to hunt down and destroy tumors. So if you block that, your ability to do this is compromised. So we do have very long side effect lists with these different drugs. They're also extraordinarily expensive, but they are becoming increasingly prescribed. So you're most likely going to have patients on these biologics. And I will say I've had patients on them with different, rheumatoid diseases and whatnot, and they have pretty remarkable sort of recoveries. Now, that's not to say that you stop the drug, they're going to go back to, normal health, but they have significant symptom improvement. So a lot of patients would rather trade the side effects with the symptom improvement, not worry about the side effects as much. But here we actually have a monoclonal antibody that can be used in MS, the natalizumab. This is a second-line therapy. There is an increased risk of what's called JC virus. This is a neurovirus that can infect when the immune system is turned down, and so forth. So these are all potential immunomodulating treatments for MS. Symptomatic treatment would be things like baclofen, which is a GABA B receptor antagonist, or agonist, for spasticity. So that's basically activating a slower GABA receptor to really work with a long-term downregulation of excessive nerve activity. So that's sometimes used for spasticity. Cholinergics for urinary retention, so giving drugs that stimulate acetylcholine or mimic acetylcholine. Anticholinergics if there's urinary incontinence. And then carbamazepine, amitriptyline for painful paresthesias. Carbamazepine is a anti-seizure med. Amitriptyline is a tricyclic antidepressant. These are used for paresthesias, and then different antidepressants. So these are all pretty common medications that you might see MS patients taking. So it's good to know a little bit about what these are. So that's the sort of overview of MS. It'd be a longer discussion in terms of, what's the role of acupuncture, herbal therapies, nutritional therapies with MS. There's a lot of speculation out there about different things that can be helpful, a lot of anecdotal evidence, not a lot of research showing benefits from these different things. But I think for MS patients, anything that can modulate the immune response, and there's a lot there that we can talk about later, can be very helpful. And clinically, I work adjunctively with the patient's neurologist. Usually they're managing the immunosuppressants and whatnot. We try to work with how do we re-regulate the immune response so that we're not seeing this overactive autoimmunity. So there's a lot that can be done from an adjunctive angle with MS. Next, we have amyotrophic lateral sclerosis, ALS, also known as Lou Gehrig's disease or motor neuron disease. And this particularly affects not the sensory and autonomic pathways, but the motor pathways. And we get loss, in this case, of both upper and lower motor neurons. So basically remember that the upper motor neurons are the neurons in the brain and the spinal cord. So if we look, for example, at the primary motor cortex and the cortex, it sends motor neurons down. They're going to cross they're going to actually synapse down here, and they're going to cross in the medulla. So if you have on the other side of the brain, they're going to come down and cross, and they're going to go down the spinal cord, and then they're going to synapse onto another neuron, which is going to go out to the muscle itself. So we call these neurons in the brain and spinal cord upper motor neurons, and this neuron is a lower motor neuron. But notice the cell body of this lower motor neuron is in the spinal cord. So ALS actually affects both the upper and the lower motor neurons. It causes death of those neurons. So it's not just demyelination, the actual neuron dies. It's a chronic progressive degenerative disease. It affects the anterior horn cells, which is where the motor neurons arise from, the lower motor neurons, and the cortical spinal tracts. So remember those tracts in the spinal cord going all the way up into the brain that carry your primary motor impulses. It's unknown etiology in up to 95% of cases. We just don't know what's actually triggering this. There is a familial genetic reason in less than 10% of cases. So we can actually identify a specific gene variant or a familial history of ALS. Again, both upper motor neurons are lost, and it's unrelenting. It's progressive. It doesn't have relapses or remitting episodes. It just continues to progress. Males are affected more than females, and the onset is usually between 40 and 80 years of age. The unfortunate prognosis is that it almost always progresses to respiratory failure and death, usually within 5 years of diagnosis. Now, there are exceptions, of course. Stephen Hawking was a good one. I think he lived for well over 30 years after his diagnosis, or much more than that. I think he was diagnosed in his 20s. So there are outliers for sure, but the typical progression is within 5 years death from respiratory failure. About 10% live longer than 10 years. And this has to do with the fact that the phrenic nerve and the nerves innervating the diaphragm stop functioning. It also, all of the upper respiratory muscles, the intercostal muscles and whatnot are no longer driven either. So a person pretty much would have to be on a ventilator. Whenever there's a compromise with these respiratory muscles, this really sets up the situation for pneumonia, for fluids to accumulate in the lungs, and usually pneumonia sets in, and that's sometimes the immediate cause of death. There are other types of motor neuron disease: primary lateral sclerosis, progressive muscular atrophy, progressive bulbar palsy, pseudobulbar palsy, spinal muscular atrophy. These are all related. I'm not going to talk about these. This is really where more advanced neurologists would kind of work up. If a patient was suspected having ALS, they differentiate these, and they have somewhat different treatment courses. The typical presentation in ALS would be muscle weakness. And I know a couple patients, one in particular, started just with muscle weakness in his shoulder. And it's asymmetric, so it's not bilateral in the body. It progresses slowly over months to years. There's no pain. It affects the arms, the legs, can affect the diaphragm, the lower cranial nerves, so that would affect the facial muscles, shoulder, and so forth. Fasciculations might be present, and muscle atrophy occurs with weight loss. And then over time, the respiratory muscle weakness occurs. A lot of patients will, at some point in the process, will need to have a tracheotomy tube placed, so they can't breathe through their mouth anymore. They breathe through a tracheotomy tube. In the limb onset ALS, this is 70% of cases, the limbs are affected first due to both the death of the upper and lower motor neurons. And that's going to be associated with upper and lower motor neuron signs, and I'll talk about those in just a minute here. And the bulbar ALS, this is 25% of cases. Remember, bulb is medulla, will present with difficulty swallowing, loss of tongue motility, difficulty speaking or slurred, kind of a nasal quality. Tongue fasciculations may also be apparent. They stick out their tongue, and so forth. Now, the limb onset ALS will eventually progress to the bulbar ALS and vice versa, but we usually differentiate them based on which presents first. Eye movement and sphincter tone are generally spared, so there's usually bowel and bladder control, unlike MS where we have the bladder issues. Sensation, cognitive function, and so forth are all completely intact. Sexual function is not affected, even in the later stages. So it's tragic in the sense that the patient is able to feel everything, their autonomic function remains intact, their cognition remains fully clear. We see that in, again, the example of Stephen Hawking, completely clear cognition, no dementia or anything like that. But all of the muscles become progressively more and more paralyzed. They lose the ability of the nerves to stimulate them. The nerves die, basically. And so the patient is just bound eventually to the wheelchair. They're often using some sort of computer interface to communicate. They still have the eye movement, so a lot of the technologies for ALS patients is to use their eye movements to control a cursor or to control their wheelchair and things like that. So tragic sort of outcome with ALS. When we look at the upper and lower motor neurons, the upper motor neurons and lower motor neuron problems will present with different clinical manifestations. So we can kind of differentiate upper from lower motor neuron based on their clinical presentations. So in particular, we start to see with the upper motor neurons, the muscle tone is going to be more, if there's a problem with the upper motor neurons, we're going to have more spasticity in the muscle tone. Initially, there's flaccidity because there's no nerve stimulation coming down the cortical spinal tracts to the peripheral nerves. But then eventually what happens is the circuits that normally should filter excess motor activity go offline, and so we get spasticity in the muscle. Versus a lower motor neuron problem is going to have more flaccidity. It's going to be more flaccid, so hypotonic and atonic. Deep tendon reflexes in the case of upper motor neurons are going to be increased. Again, initially they'll be decreased or normal, but eventually they'll be increased. So it's like there's no break on that nerve activity. So think upper motor neuron spasticity, hypertonicity, and then lower motor neuron will have decreased reflexes. And then miscellaneous signs, there'll be the Babinski reflex. That's an abnormal plantar reflex. That's a sign of an upper motor neuron problem. And then in the case of lower motor neurons, we're going to have atrophy and fasciculations of the muscle. So that's kind of some of the clinical features here between upper and lower motor neuron diseases. So again, in ALS, it's really going to affect both and at different times during the disease progression. The history and physical exam are usually diagnostic, usually with the bulbar involvement, the tongue, which is innervated by cranial nerve number 12, and the oral pharyngeal muscles innervated by cranial nerve number 9 is going to symptomatically present problems with the tongue fasciculations, difficulty swallowing, and whatnot. EMG and nerve conduction studies. It's going to kind of reveal widespread denervation and what are called fibrillation potentials. And that's usually only done to exclude other potential demyelinating motor neuropathy. So there are many others I'm not talking about here, but there's others that might cause signs and symptoms similar to ALS. they would have a different etiology. And then usually a CT MRI of the cervical spine is done to exclude any structural lesions in the cervical spine that might be compressing the cortical spinal tracts. But the treatment, unfortunately, pretty much is there's only one pharmacologic therapy, that's riluzole. And this blocks the voltage-gated sodium channels. It also inhibits the kainate NMDA receptors, which are glutamate receptors. There is an incidence of liver damage, but this unfortunately only extends lifespan another 2-3 months in most patients. So riluzole is used, but pretty much we don't have much success with it. Supportive measures would be breathing support, and that would be the tracheotomy, that would be potentially ventilation, and then physical therapy and fitting a patient for the wheelchair and things like that. So horrible outcome with ALS. And again, I wish I could say that there were adjunctive care options that we know are tried and true that can improve patients with ALS. I know many ALS patients have gone through acupuncture, herbal therapies, homeopathy, all of this, and their condition continues to progress. There are a couple of cases of ALS patients who actually did a lot of the naturopathic route and continue to do that, and they lived for well over 10 years with their ALS and had limited function, but were able to function with their family supporting and so forth. So it's possible that all these other therapies we can offer can help extend the lifespans of ALS patients. But that's a little bit about sort of the biomedical approaches that you need to be familiar with. The last condition I'm going to talk about here in the neuromuscular disorder section is Guillain-Barré, or acute inflammatory demyelinating polyneuropathy. And this is an acute, rapidly progressive, acquired, in other words, acquired from something else, and very common reason for this is immunizations, demyelinating autoimmune disorder of the peripheral nerves. So unlike an MS, where we have loss in the central nervous system, here there's a demyelination in the peripheral nervous system that affects all the nerves, so sensory, motor, and autonomic. And that typically manifests as muscle weakness. There's different variants, and sometimes the myelin is directly attacked, and other times it's more the nerve axon itself that's attacked. It can be associated with different things. I mentioned immunization. Flu vaccine is a common one. In fact, when patients present with Guillain-Barré in the emergency room, one of the first things they ask you is, did you have a flu vaccine recently? Can be associated with Campylobacter jejuni. This is a common cause of a GI infection. And then there are viral infections, GI and respiratory, that often can trigger, also can trigger Guillain-Barré. Good news is about 85% make a complete or near complete recovery. It may take, though, up to a year to regain function. The mortality rate is less than 5% with Guillain-Barré. And the history and the presentation usually involves progressive over days symmetric ascending paralysis. So it goes from the distal muscles like the hands and the feet towards the trunk. So distal to proximal. And there's often numbness, tingling, and pain. It involves the trunk, the diaphragm, and the cranial nerves. And an atypical presentation might include sort of rapidly progressing to the respiratory muscles again, just like we saw in Myasthenia Gravis. So that would result in respiratory paralysis. And then there's autonomic dysregulation as well. So think here, this is kind of like the process that's happening in MS, which happens in the CNS. This is happening in the peripheral nervous system. And so the myelin degenerates and the nerves are exposed, and that's going to decrease conduction, decrease function. So the diagnosis is often done through nerve conduction studies, and there's evidence of diffuse demyelination in this. And then lumbar puncture might actually show elevated proteins in the cerebral spinal fluid with little or no white blood cells in the CSF. If there's evidence of respiratory failure in these patients, we admit to the ICU immediately to be put on a ventilator, and then plasmapheresis again, putting the blood through that filter to remove antibodies, and different treatments can be given first line there, and corticosteroids here are not indicated, and then aggressive physical rehabilitation. So typically the care is kind of supportive immediately if there's respiratory failure. But then it's hoped that over time, whatever triggered that immune response, that immune overactivity will calm down. And again, over 85%, up to 85% of cases recover within a year. So we think that patients who, for example, get the flu vaccine and get Gynberry, they already have a predisposition towards hyperactive immune responses. And that's where adjunctively we can work a lot to see if we can do something to downregulate their autoimmunity. And again, that's a different discussion about how do we work with autoimmune disorders, and we can talk about that later. So that summarizes it for the basic neuromuscular disorders that you need to be familiar with.